good morning. As you know, my name is Shahd Faris. I'm here from PACademia. Today I'll be explaining for you and maybe reviewing with you motor tracts. It's an anatomical lecture and we will go through its clinical basis. Tracts, they have a lot of injuries, there are specific lesions, and once your patient comes to the clinic, you have to think of it from the symptoms wise that are showing on your patient more than starting to approach it in a surgical way. So to start with, back in foundation, as all doctors mentioned this sentence, you took the anatomy of the spinal cord. And we want to discuss it. We know that there is mainly two things, the gray matter and the white matter. So just I want you to get familiar with that. This is the gray matter and this is the white matter. Okay, because we're gonna need it now, later on. And then after you're discussing the spinal cord, you're gonna know that there are two stuff coming out from the spinal cord. There are the signals that are reaching to the specific muscle, to the specific sensory part. These are called the tracts, or like coming back into the basic name, which is the neurons with their axons and with their nucleus bases. So what do we call them? We call them tracts. Now, since this lecture is talking about motor tracts are basically just made of two neurons, which is the upper neuron and the lower neuron. Why is this important? Because once you're going to come to the sensory tracts, we have three neurons, or three synapses going to happen. So for the motor, as it's concerned, we're going to talk about two things. First, we have the upper motor and then the lower motor. And the lesion in upper or lower, as you know, is going to differ with us in the clinical basis. So let's just have a look at the upper motor tract. It's going to start from the cortex of the brain, the upper part of the brain, and it's going to descend down until it reaches the specific nucleus it wants to anastomose with, or let's say in a more anatomical word, synapse with, and give us the lower motor tracts. Now the lower motor tract is going to differ basically based on what neuron are we sending. So like as you can see in the upcoming slides, we have different nucleuses in our brain. The lower motor tract is going to start from based on is this neuron carrying what type of movement? Is it going to carry a voluntary movement? Is it going to carry an involuntary movement? So just familiarizing ourselves with these vocabulary. Now getting to the real work, it is the descending tracts of the spinal cord. And once we hear the word descending, we're coming back from up to down. Up to down means we're talking about motor tracts. And the opposite, sensory tracts, will be taking signals from, let's say, fingers, touching, smelling, up to the brain. So they will be ascending. The descending tract, this pyramid is really simplifying it for us. It contains three main things. One, we have the pyramidal tracts, we have the extrapyramidal tract, and we have the descending autonomic fibers. Now, once you hear the word pyramidal tracts, you have to keep two things in your mind. It's called corticospinal, and the second one is called corticonuclear. These things, they are from the spine, all along the spine. They're not going to stop in a specific place. The corticospinal, from the word. What does cortico give you or indicate for you? Cortex. And the spine is going to then descend down to the spine. However, corticonuclear, is there a spine in the word? No. So it's going to stop in the head, and it's usually giving to the cranial nerves, as we're going to see later on. The extrapyramidal tracts, I want you to keep thinking of it, that it's extra or out of your control. When you say some stuff are out of my control, they're extra of my control. Because once we're going to discuss the extrapyramidal tracts, we're going to talk about movements that are involuntary. So this is going to help you memorize it. And the last thing is the autonomic fibers. As we mentioned before, parasympathetic and sympathetic tracts. It's not usually really here concerned in our lecture, but just for your information. So let's start with the corticospinal tracts. Now, after just remind ourselves, we have the pyramidal we said corticospinal or corticonuclear. Once we come to the corticospinal, it's also going to give us two branches. These two branches are the lateral corticospinal and the ventral corticospinal. And the name lateral or ventral are going to indicate for us the place in the spinal cord. Now, what's also we have to see, once we see the word corticospinal, is the mic annoying you guys? Or is it fine? Okay, good. It's voluntary. It's every movement that is voluntary. Like for example, if you want to stand, you're going to push your muscles to stand. But once you're standing, the muscles, how they're holding their bones, what we call the muscle tone. Are you aware of the word muscle tone? Muscle tone, are you controlling your muscle tone? No, this is extra, out of your control. This will gonna be for the extrapyramidal. But once I'm saying, you want to move your hand, you want to shake your hand, you want to do anything, this is concerning the corticospinal tract. So this is gonna help us now when we have a lesion in this part, we're gonna know what part will be affected. Is the muscle gonna be paralyzed completely, or is it's gonna be like the tone of the muscle is gone? So it's gonna be based on if it's the pyramidal or the extrapyramidal. We mentioned that the extrapyramidal is involuntary, and we have to talk about the reflexes. So reflexes, they're also part of the involuntary actions that we do. And we have the two types of reflexes, like for one of the example is the knee reflex. Once you hit a knee in any clinical scenario or in the OSCE, you see that it's gonna reflex, but it's not in your control, it's out of your control. So, for example, when we say that the extrapyramidal tract is injured, and how would you expect your patient to be in a clinical scenario? Like you have a baby, for example, and this baby, you want to test if the extrapyramidal tract is injured or not. What would you do? Sorry? You're gonna check the reflexes, exactly. So this is how you keep it in your mind. And the balance of the body, like you're trying to balance your body when the person is walking. As we're gonna see, there is a full lecture for the balance of the walking or balance of the gait. You're gonna see it in the extrapyramidal. And the autonomic fibers, we discussed sympathetic and parasympathetic, which are concerned with the innervation of the visceral organs, the heart, accelerating the heart, controlling the other organs. Now, if you take a segment of the spinal cord and we're gonna look into it, you're gonna see that each place in the spinal cord, or let's say each row, has a specific tract inside it. So as you can see here, the lateral corticospinal tract, it's here. This is where we're gonna expect the tract to be found. Here you can see, we're gonna see the anterior corticospinal tract. So it might be really useful for you just to organize yourself and try to memorize where each one. And this is going to be more important in the sensory tracts. The motor tract is basically lateral or anterior, so not that much. So, okay, discuss this, yeah. So, now I want to come back to the extrapyramidal tract here. Why when there is a lesion in the corticospinal is going to cause paralysis?
We control these muscles.
Yeah, okay, you answered me before I could take the question. صح ليش انه هلا احنا when you say why I wanted to say بالcorticospinal once there is a lesion حيكون في paralysis completely of the muscle and هم المسؤولين انه يصير في عندنا control المسلز. بس تبع extrapyramidal when there is a lesion in the extrapyramidal we're not expecting to be a pyramidal. We're not going to expect to be a lesion. And there is an interesting theory behind this is that these tracts, what are they controlling? The corticospinal tract, in their nature, they are excitatory.
Sorry to interrupt us.
Yeah.
Did we take this with Dr. Ahmed?
لا. ما أخذتوا هاي السلايد؟
No.
Oh, because I was like, is this year 3 step or what?
هلا okay, it's gonna help you in the lesions. You took the upper motor neuron lesion and lower motor neuron lesion, صح? I'm gonna explain it briefly, and هلا we're gonna see if you took it or not. But this is really gonna help you to classify your thoughts with these tracts. They're gonna cause paralysis or it's gonna cause overexcitation of the. Yeah, it's very simple. هلا I'm gonna go through it.
It's fine.
Corticospinal fibers, in their nature, they're excitatory. So their signals will go to the muscle and excitate it. It's making it contract. So once you cut the excitatory, what are you expecting? Paralysis. But coming to the reticulospinal, these are the extrapyramidal. And the reticulospinal fibers, vestibulospinal, or part of the extrapyramidal tract, they're inhibitory. But I want you to differentiate between two things. So once you cut the inhibitory, what will happen to the, let's say, the part where over activation of it? Because خلاص, we're cutting the inhibitory, nothing is stopping it. As if you're thinking of a car, you cut the brakes, the car is going to go out of your control. So once you cut the reticulospinal fibers or the inhibitory fibers from the extrapyramidal tract, the muscles are going to have an overactivation, hyperreflexia. The tone of the muscles is going to go into spastic paralysis, which is we were talking about spastic, that it's contracting continuously. So just know
This is for the lower tract?
No, this is for the upper. And we were talking about corticospinal, and you see it still did not reach to the nucleus or synapse. So, okay, now back to the function of the corticospinal. We said agreed that it's all controlling the voluntary movements, and we want to see where is exactly we can find these tracts. Since here we're talking about corticospinal, we said there are two stuff for it: lateral and anterior. So once you look at the spinal cord segment, you're gonna see this is the anterior corticospinal tract, and this is the lateral corticospinal tract. But a question rises here: are these tracts standing in their original place where they came from? That once you're looking to, let's take a segment L2 on the spinal cord. Is this lateral corticospinal tract coming from the same side if you go up to the cortex?
There's also the other side.
Yes, I know there is also, but just focus on it. If I'm taking this lateral corticospinal cord at L2 segment, and I keep walking with it, am I going to reach the same? When we're talking about the right, am I going to reach the same right part of the cortex? No. We agreeing on this? This is no. But what about the anterior?
The same.
It's the same. And this is going to bring us to the point that the corticospinal tract, there is a small trick in it that 80% of the tracts, they're called the lateral, and they were going to decussate. What we mean by decussate, that they will cross and go to the other side. But the anterior, which is only making 20% of it, is going to stay in the same direction. So once you see a cord with the anterior, this is meaning it's the same direction of the where it's originating from the cortex. But once we're looking at once we're looking about the lateral, it's not its original place. So this is also going to see it in our clinical basis. Now, and as you want to memorize this, that when you're saying anterior, as if you're telling someone, okay, anterior direct. So there is no decussation, which is the anterior corticospinal, the same idea. Let's say that it's coming from the left, it's going to be coming down, say in the left. Anterior direct. But the lateral is going to be, it's the opposite side. Okay, so this is the same thing. You can see that we're starting here from the left, it's saying, but the lateral is decussated down. The question here comes, where exactly do they decussate?
Medulla?
In the medulla, exactly. So in the medulla, the decussation is going to happen for all the lateral corticospinal tracts. So if there is an injury happening in the lower spinal cord, it's going to differ with us from an injury happening maybe up inside the medulla or inside the cortex. So just memorize it in the sensory tracts. There are different places of decussation as well. So once you know each tract, where does it decussate? Now once we're going to start solving questions, we're going to see حتفرق معنا exactly الانجري وين كانت. So we are agreeing, where is it? بالمنطقة. هلا you have this lecture, this slide in your PowerPoint. It's just basically describing what we have discussed. Where exactly فيها extra details. If you want to go through it, it's fine. But the main idea we took it. Okay, هلا هون for the pyramidal tracts, again emphasizing on the point that we have motor, 2 neurons, upper and lower. And the sensory, you're gonna have 3. If we're thinking of it, the upper start from the cortex, gonna descend where we want to reach. But the lower, it's gonna start from the nucleus, so we're talking about lateral or anterior, to the muscle. This is called the lower motor neuron. Let's take now ourselves into a clinical scenario. You have a patient, after they're examining them into maybe any modality of imaging, they said that there is a lesion of the right lateral corticospinal tract at L2. And now basically you took the plexuses in the upper limb and you took the plexuses in the lower limb. So what will the impairment be produced from this lesion? And the lesion lateral corticospinal L1. And you can see on the picture, it's right or left? Right. Okay, who can tell me? Yes.
There will be paralysis in the right side of the body.
Right side? Yes, excellent. Type. What about the upper limbs? Do you think they're going to be affected?
No, because brachial plexus is between C5 and T.
Yes, excellent. So here we're talking about, once you see a question, let's organize our thoughts and see how we're going to approach it. First thing you're going to think of, what is disrupted? And this question, it was the lateral corticospinal. So this lateral corticospinal, where does it decussate? Medulla.
Contralateral.
Yes, contralateral بالمدلة بس احنا حكينا لك الليجن وين؟
No.
الليجن مش بالمدلة، الليجن in the spinal cord.
It's
it's ipsilateral.
So if the lesion was above the medulla, the problem would be contralateral.
Exactly. This point is summing it all up. Did we get that?
No.
Again. Sure. احنا اتفقنا corticospinal tract is gonna start from up the cortex going down in the medulla. هتيجي تحكي I wanna change my mind, I wanna go to the other direction. It's gonna decussate, cross. كانت right صارت left let's say. After it's reaching to the left خلاص it's gonna walk in one direction. هلا once it's going in this one direction إذا صار في عندي injury this space when what's gonna happen? The injury راح يكون نفس الدايركشن. طيب going back to the cortex. الليجن صار عندنا بالكورتكس بالرايت سايد. هلا it's gonna affect مين؟ left basically. ليش؟ لأنه احنا لما نكمل مع التراكت حنشوف إنه التراكت is gonna be injured in the opposite side لأنه بعد ما احنا we cut the tract قبل ما it decussates. Clear? Yes please.
If the ventral corticospinal tract is still intact, they will still have some ability to contract.
Yes, but it's 20%. يعني what are you talking about? The motor of 20% of the neurons. Maybe it's gonna be very minor. We're taking it into proportions. حتى once you see a clinical scenario, it's mostly gonna talk about the latter. Did we get that? 100%. How it's gonna decussate and where's the injury gonna matter with us? طيب. Last thing we're gonna ask ourselves. هلا we decided where's the place. عرفنا إنه هون بما إنها it's right. It's gonna be the right lower limb. لأن احنا حكينا lesion L1. Now we wanted to ask ourselves which function will be lost. حنرجع نشوف مين اللي tract. Which tract got disrupted. Lateral corticospinal. Lateral corticospinal شو الفانكشن تبعه؟ Voluntary movement. So what's gonna be lost for the muscles تاعنا؟ Movement of the muscle. Exactly. بس رح يجيكم سؤال. Is the muscle tone affected?
No.
رح يجيكم سؤال ثاني. If we put an electrical impulse على المسل, is it going to be start working normally?
No. Yes.
Yes. لأنه خلص إحنا المشكلة بالضبط voluntary. So okay, بس here we're not yet. This is not the full description of what we want from you. حتى بالoptions you're gonna see it in the exam. Now we have to take ourselves into other tracts because this lesion can affect different tracts and can affect more than one function. So just telling me the voluntary movement is not enough. We're gonna see now the other tracts, just gonna pass through it this one quickly, is the corticonuclear tracts. The corticonuclear tracts, its name saying in the nuclear of the head, it's not gonna أصلا reach down to the spinal cord. But we have to know only 2 points around this corticotrianal tracts. أول شيء حكينا terminating in the brain stem. Terminating in the brainstem corticobulbar, it's the same thing. Corticonuclear or the bulbar, it's the same thing. And it's contralateral to the branch of its coming. مثل corticospinal, and once you're gonna see a lesion with cortex in the right, which cranial nerve will be affected, which facial nerve حتكون on the left. Just 2 points, summarize it, simplify it on yourself. It is ending in the brainstem, it's contralateral. طيب هلا coming back to the extrapyramidal tract. You took this صح guys? You did not take the extrapyramidal tract?
We didn't take motor أصلا.
You took the sensory?
Just sensory. Motor will take it next week.
Okay. طب how are you going with it? Do you think it's simplified for you? لا الموتر. Motor is fine. Do you want me to continue ولا أروح أكمل على الsensory?
Sensory.
You want to complete in the sensory? هلا how is the sensory with you? Did you guys study it?
I forgot.
Okay, so بما أن الsensory والmotor will be approaching the finals حتى you're going to be close to the final period يعني just try to get yourself familiar with it. Do not go deep in the lecture. I'm going to try to simplify the motor tract حتى بس تكونوا it's close to the final تكونوا you're getting rid of it. It's very simple. So if there is anything unclear, just let me know. It's the idea of the motor and the sensory is basically the same. حتى you saw it in the slides. يعني بس the idea هناك عندنا 3 tracks and 2 tracks. حتى we usually start with the motor because it's more well organized than the sensory. So far so good. أكيد. Okay. So the extrapyramidal tract, sure, since you did not take it, in the extrapyramidal tract here we're concerned with their function mainly. We're not concerned exactly where their place because their places is like very wide, very complicated. One is gonna decussate to this direction, one is gonna cortical say to this direction. So in our time, the doctor said, I want from you only the function of the tracts. What's going to be and what's going to be affected. So we have the reticulospinal tract. The reticulospinal tract, it's the strongest inhibitory of the alpha, اللي هم يعني, in other words, of the muscles. So as we said, what was the most excitatory? Corticospinal. What is the most inhibitory? Reticulospinal. So keep it in mind. Corticospinal, when we say cortico, it's exciting the muscles. Cutting it will cause paralysis. Reticulospinal, it's the strongest inhibitor. You cut the brake, remove the brake, it's gonna go crazy. And what we have to know about it, it's gonna control the muscle tone. It has some autonomic functions, and if injured, it's gonna be hyperactive, لأنها inhibitory. This is basically what you have to know about this tract. The vestibulospinal, it's gonna give you a balance while walking or jumping. هاي هي المين بتاعتها. It's mainly balance. And the vestibulospinal, it's excitatory للextensors. Extensor muscles, every part we have a specific muscles extensor. They have an excitatory للextensor. هاي الvestibular. Inhibitory للflexors. Why is this important? لأنه في عنا another ugly guy اللي هو rubrospinal tract. It's gonna do the opposite. It's gonna make an excitatory for flexors and inhibitory for extensors. This يعني just get yourself familiar with it. The vestibulo, we're talking about here balance. Same thing. This is a cute guy. Vestibulospinal, excitatory extensors, inhibitory للflexors. Rubro, the one we hate, it's excitatory for flexors and inhibitory for extensors. Tectospinal tracts, it's mainly for reflexes and postural movements. These reflexes are concerned with vision. So once you're just going to see that there is a fire in front of you, you're going to run. You're going to see a dinosaur in front of you, you're going to run. This is mainly concerned with the tectospinal tracts. So the questions are, what's required from you mainly to know if there is an injury to the reticulospinal mentioned for you. You're going to know what function is lost. If there is a rubrospinal, it's cut. So what we're going to inhibit by this. Okay, so now our legends, the one we are following and guiding us, Ahmed Farid explained it for us and summarized it in a small table. It's the upper and the lower motor neuron lesions. It's going to differ with us if it was in the upper motor lesion or the lower is injured. In the upper motor lesion, we have two stuff in the upper motor neuron. It's going to either we're inhibiting excitatory اللي هو corticospinal. It's an excitatory corticospinal. فإحنا we're cutting مثل البنزين. What will happen? There will be paralysis. But if you remove the brake اللي هم extrapyramidal, what's going to happen? Hyperextension. Exactly. So the upper motor neuron lesion is going to start from the cortex. لا, basically the specific parts we're talking about. مثلا, if the lesion is happening, let's say at T1, it's going to be upper يمين or lower يمين. T1, if there is a lesion in the spinal cord at the base of the synapses, if it's happening at T1, it's going to be lower لكل المسلز اللي طالعين من T1. بس it's going to be upper يمين كل المسلز اللي نازلين تحت اللي هم lumbar plexus, كل muscles that are innervating the lower parts. But it's really important for you to know if this lesion is happening here, is it going to be lower or upper يمين or lower يمين. And into you're affecting the upper part here. هتكون at the same direction, let's say, of the brachial plexus, فit's lower. But if it's affecting the same lesion, بالنسبة لللumbar, upper. Okay, now we have to know the example of it can be variant example, stroke, head injury, a specific part of the spinal cord is injured. Now, what will be result? The voluntary movement is going to be paralyzed, and we agreed why on this. Why is the voluntary movement completely paralyzed? Why do you think? Excitatory راح. مين هو excitatory? Corticospinal. That's really what you have to know. Corticospinal upper motor neuron راح. هو مسؤول عن voluntary فصار عندك paralysis. But not only that. When we have to talk about the hypertonia. مين المسؤول عن hypertonia؟
ثاني
اللي هو extra صح؟ involuntary. شو اسمائهم؟ Reticular. هذول inhibitory. We remove the brakes. صار عندنا hypertonia spasticity اللي هو يتوك spastic paralysis اللي هي the muscle is innervating itself more than once but it keeps contracting فهاي it's called hypertonia or spasticity. at the same time we're having paralysis بس كمان عندنا hyperspasticity بالupper motor neuron lesions لأنه في عندنا هيك وفي عندنا هيك. same scenarios سووا لهم opposite هي lower motor neuron lesions. Basically this is going to summarize it for you. Coming back to this slide, if we're going to look at this picture, رجعنا حكينا لكم we have a lesion at the right lateral corticospinal tract. What impairment? حكينا أول إشي اتفقنا على مين؟ الرايت lower limb. شو رح يصير فيهم loss of what؟ Voluntary. طيب بس هلا بعد ما أخذتوا الكورتيكوس reticulospinal tracts اللي هم extra pyramidal. If they're lost شو رح يصير غير paralysis of this lower limb؟ Spasticity. فهيك هلا you got to understand that the previous answer was not enough based on just only knowing the first tract. This second tract is gonna help us إنه gonna see there is increasing more than the paralysis رح يصير عندنا hyperreflexia and عندنا hypertonia لأنه إحنا we removed the brakes. The brakes ما لهم علاقة they're not related to the muscles.
مش الكورتيكال كان اكسنتري؟
corticospinal.
احنا هلا الريتيكال.
احنا هلا شوفي we talked about corticospinal. At the first question أعطتكم إياه مين أعطينا الليجن؟ رح يصير paralysis of the lower limb. خلصنا السؤال سوينا stop we put full stop صح؟ هلا بعد ما أخذنا الإكسترا بيراميدال غير الباراليسيس هدول كمان موجودين يعني paralysis هو هدول. So it's a paralysis hypertonia لأنه قمنا البريكس المسؤولين عن المسل تون. اللي هم الإكسترا بيراميدال reticular spine. Got it why؟
لأنه it's there معاها يعني.
Yes هلا هم الاثنين هم عندنا احنا two guys are responsible for the function here. الكورتيكوسباينال اللي هو بيشغل المسل بيحكي لها voluntarily movement وفي عندنا another guy مين هو عن شو مسؤول؟ عن التون. فإذا احنا قمنا الكورتيكوسباينال خلص هذا هو مش كان عم بيشغلها يعني he's involving it to move. It's gonna lose the paralysis effect. طيب الother guy كمان إذا قمنا شو رح يصير؟ قمنا البريك قمنا الاكسترا بيراميدال. This is what I want you to get. إنه مش only one paralysis حيصير عندنا لا كمان حيصير عندنا hyperreflexia لأنه إحنا مش one tract عم نحكي عنها عم نحكي two tracts. Since we took the two tracts. The first question I wanted you to answer بس based on the corticospinal لما كنا ماخذين the next tracts. Did you get that? أكيد. Move on. في حدا مش فاهم؟ I want me to repeat. I repeat لأنه هاي هي أهم يعني this is the most important point. بعدين هلا we're gonna see the regions based on this.
Okay, one more time.
One more time. Let's get our thoughts organized. هلا إحنا عندنا الليجن. أول إشي نسأل حالنا بالليجن في two guys مسؤولين. corticospinal ومين؟ reticulospinal اللي هم extra pyramidal. pyramidal هم لمين تابعين؟ corticospinal. If you want me to go back to this picture. The pyramids. هلا احنا هذول spinal cord basically هذول. احنا هنحطهم orthos. pyramidal هو مسؤول انه يشغل. It's responsible for moving the muscle, voluntary movement. extra pyramidal هذول extra out of your control اللي هم tonia, the muscle tone. So let's take our issue. Let's look at the pyramidal tract. If you remove the pyramidal tract, paralysis. The muscle is not able to move. Interpyramidal tract, forget it. Let's talk about the extrapyramidal tract. You remove that. هذول هم اللي breaks. Remove the brake. The car will go crazy. فأول question أنا بسأل حكيت لكم إياه صار عندنا lesion بالرايت spinal cord. بما إنه صار عندي هون lesion بالرايت spinal cord وإحنا بنعرف إنه هذول التراكتس they قصيت فوق بالمدلة يعني هم خلص غيروا اتجاههم و they took one road. We cut them in their already road فالlesion is gonna be in the same direction. هذول corticospinal. Once the lesion here in the right عرفنا شو هو lesion we look at and ask ourselves what is the tract that is injured? Corticospinal. Corticospinal is injured. شو الfunction that's going to be lost? Voluntary. Then we discuss the extrapyramidal. Extrapyramidal مسؤولين عن مين؟ tonia. من الextrapyramidal we injured them. هم مسؤوليتهم مش مثل الreticulospinal they're not the good guys. They already inhibit. So we remove the inhibitors, hyperflexia. So once you see this in a clinical basis, you're gonna think of it in two ways. You're gonna think what is the muscles that are removed, and what are what are the tracts that are removed, and what is their function. انتوا بتعرفوا يعني tracts where are they decussating؟ إذا عرفتوا when they're decussating they're gonna know is it ipsi or contralateral. وبعدين إذا عرفتوا what is their function حتعرفوا it's hypertonia, hyperflexia.
The extra pyramidal ones inhibit, then from where the excitation comes from?
هلا do you know in our body احنا عندنا excitator وinhibitors. And مثلا إذا we're talking about the muscle tone, there are specific neurotransmitters that are released from the extrapyramidal that's gonna inhibit the tone of the muscle. مثلا when we want to increase the tone في some certain drugs you took it بالpharma lecture اللي spasmolytics وهيك. If you want to increase the tone حطيتوا neurotransmitters that are gonna take the place of the actual ones. فهم ما حيبطلوا يشتغلوا. We inhibit them. نعطي أشياء to block their receptors.
Yeah, but which tract there is that
Excitatory tones. Well, I'm not actually sure عشان ما أفتي. If you want to get back to it, بس أنا what I know زي إحنا عندنا بالbody. If you want to make something work بتشغله. إذا ما بدك إياه بتطفي هذا خلاص. It's gonna inhibit itself or it's gonna work to itself. So you can check it online if you want. But this is what is concerned with your lecture. Did we get it now? أكيد. يعني this is the main of the lecture. بدك نطلع خلص فاهمينها ومرتاحين فيها بدل ما open tons of YouTube videos to just get yourself confused زيادة. Clear?
How did you know that ventricular fibers were involved in this lesion?
It's given in the question. It's هو حيحكي لك it's given yeah. يعني حتى if not this way, it's gonna be in the opposite. حيحكي لك صار عندي paralysis and صار عندي hypertonia. خلاص انتوا you flip the way how you think of it. هتحكي انه صار عندي hypertonia مين اللي راح؟ paralysis مين اللي راح؟
corticospinal.
لو كانت الليجن حكينا بالرايت it will affect the left صح؟
لا حسب احكي لي الليجن كمين سؤال.
لا الليجن بالكورتكس يعني عمل فوق كورتكس
يس ايوه خلاص اذا كانت فوق صح it's gonna affect left exactly.
رايت ليجن في الكورتكس left.
left مين left limb lower limb
left بالspine it means left paralysis.
Here. هلا we describe it here. We agreed that it's gonna give us based on these two tracks that we studied. You have this. Okay. So the upper motor neuron lesion. أعطانا doctor examples of it. What do we expect to see as a clinical base that's gonna affect the upper motor lesion? Stroke. It's affecting basically the cortex. فخلاص انتوا حتفكروا فيها upper motor neuron lesion. إذا كان عندنا مثلا brain stem or spinal cord injury هدول كمان is gonna affect the upper motor neuron. Basically يعني they're giving you clinical scenarios where your patient can come with this injury. Now حكينا if the injury was in the midbrain or in the medulla, contralateral ولا ipsilateral. هما they're decussating in the medulla. If the region was in the you mainly you put it contralateral. Okay. طيب هل this is the idea I was explaining. This diagram is gonna explain it more. إنه the lesion is gonna matter with you. إحنا حكينا the region of L1 كانت it's gonna affect the lower limbs only. كانت upper than lower limbs. But if I'm talking about مثلا let's look at this area exactly. If I'm talking here, this lesion is gonna be upper لكل الأشياء اللي نازلة هون. It's gonna be lower للأشياء اللي حتطلع من هون. I don't think they're gonna go into details with this. بس إنه يعني إحنا to organize our thoughts. We're gonna know إنه specifically in this region في ناس حتكون مكملة وفي ناس حتكون خلاص this is the lower تبعها. فwe're gonna know based on which segment is gonna cross. Now هلا lower motor neuron lesion وأكيد they're ipsilateral ليش؟ لأنه خلاص إحنا صرنا بالlower motor neuron lesion there is no decussation. These lower motor neuron lesions عندنا based on different diseases there are causing مثلا either the muscle, either the junction, the neuromuscular junction that's gonna between the neurotransmitter and the muscle itself. مثل myasthenia gravis, we took it with Dr. Rizwan. Like it refreshed your memories. Did you take it?
Yes.
Yes. So it's gonna affect the lower motor neuron. We're expecting the case to be ipsilateral. Sciatica
it's it's the nerve that is innervating the lower limbs. If it was affected هو النيرف هذا السciatica, it's going to go to the muscles خلاص. This is the end branch of it. It's gonna go innervate the muscle. If we're cutting it, we're cutting the lower motor neuron region. طيب هلا let's just ask ourselves. Let's say that we took an injury to the muscle itself. So we cut كل الnerves اللي they're going through the muscles. Basically our upper ولا lower.
شو
صفنت خلاص we're almost done.
Yeah.
If we're taking a muscle and we cut the nerve supply that's going through this muscle, upper ولا lower? Lower. يعني this it is the basic of it. Oh, that's gonna summarize for us upper or lower motor neuron region. Once you're gonna take the lecture, you're gonna see other parts that other clinical manifestations. يعني اسم disease, شو motor tract that is affected of it. We're gonna just give you a couple of symptoms for it. The other is really easy. This is the dance of the lecture. And with this, we reach the end of our lecture. Thank you so much.
Question.